To everyone in today's section of the growth hormone disorder video. First, here we see the various disorders like the dwarfism, gigantism, and acromegaly that has been due to the growth hormone deficiency. First, we see the dwarfism. What actually dwarfism is, and what are the various types of the dwarfism as well as treatment of the dwarfism. Here we see there is the deficiency of the growth hormone in the children that results in dwarfism. And causes of the growth hormone deficiency could be any stage in the axis of the hypothalamic anterior pituitary target tissue axis. Any defect can result in the growth hormone deficiency. Defect in the hypothalamus can result in the decreased secretion of the growth hormone releasing hormone, and that result in decreased secretion of the growth hormone from the anterior pituitary that result in the dwarfism. And that happened due to the failure to generate the somatomedin or the insulin-like growth factor from the liver, and the deficiency of the growth hormone of the somatomedin results in the growth hormone resistance. Such things happen when there is any defect in the hypothalamic anterior pituitary target tissue axis. Next, we see the types of the dwarfism. First, we go through the Laron dwarfism, where there is the defect of growth hormone receptors, and although the growth hormone is being secreted and synthesized at the normal level from the anterior pituitary, but due to defect in the growth hormone receptor, there is the reduced growth of the body. So treatment with the growth hormone is ineffective because the defect is in the growth hormone receptor, not in the release of the growth hormone from the anterior pituitary. Next, we see what things contribute to the defect in the growth hormone receptor. That is mainly the mutation of the gene that encode for the growth hormone receptor. So that may result in either absence or production of the dysfunctional receptors. So even though the pituitary gland produces plenty of the growth hormone, but the liver couldn't get the signal for the secretion of the insulin-like growth factor 1 or somatomedin from the hepatocyte, that may result in the severe postnatal growth failure despite the higher normal level of the growth hormone in the blood. Next, we see the clinical features of the Laron dwarfism. First, we go through uh, the picture of the Laron dwarfism, the mechanism. First, we see the physiological condition where the anterior pituitary gland is secreting the growth hormone, and that normally bind to the growth hormone receptors of the hepatocyte, and once it bind to this receptor, then that will stimulate the release of the insulin-like growth factor 1 from the hepatocyte, and that results in the growth, proliferation, and the various other metabolic activities. And this increased amount of the insulin-like growth factor will send negative feedback mechanism to the anterior pituitary gland to regulate the secretion of the growth hormone. But here what happens in the Laron syndrome, this growth hormone is normally um, released from this anterior pituitary, but there is the mutation of the growth hormone receptors in the hepatocyte. So there will be a reduced signal to the hepatocyte or no signal to the hepatocyte to release this insulin-like growth factor. So this reduced insulin-like growth factor will produce the reduced feedback inhibition to this anterior pituitary, and there will be even more released the increased release of the growth hormone from the anterior pituitary. So although the growth hormone is more, but due to defect in the growth hormone receptor, there is the reduced insulin growth factor, so reduced growth and proliferation as well as metabolism and increased apoptosis can be seen in the Laron dwarfism. So various clinical features are proportionate short stature and prominent forehead, depressed nasal bridge, and appear younger than their chronological age, truncal obesity, hypoglycemia, especially in the children due to the low insulin growth uh, factor, and high serum growth hormone, but there will be the low serum insulin growth factor 1 in the Laron dwarfism. Next, we see small genitalia and the delayed puberty due to the reduced release of the insulin growth factor and so many other growth factors that act on the various tissues for their growth. Next, we see the pain hypopituitarism or pituitary dwarfism. Here we see there is the defect of pituitary gland to produce one or more of its hormone, and in the dwarfism, most affected is growth hormone cells. And panhypopituitarism, there is the deficiency of all the pituitary hormones like the growth hormone, TSH, ACTH, FSH, and LH, and sometimes ADH as well. And that could be caused by various congenital as well as acquired cause. And the congenital could be genetic mutation in the gene that are required for the normal development of the pituitary gland, and that gene could be like POF1, F1, PROP1, and the various acquired cause could be like the tumor, craniopharyngioma, trauma, infection, or any radiation to the pituitary gland that damages the cell of the pituitary gland. And the mechanism of the pituitary dwarfism is that without growth hormone being produced and secreted, the liver is not triggered to produce the insulin like growth factor 1, and so there will be the reduced growth, and that results in the proportionate growth failure, and other critical manifestation can be seen due to the defect in the thyroid hormone, adrenal hormone, and other sex, and defect in the sexual development due to the reduced ACTH hormone being. And next we see the clinical features of the pituitary dwarfism. Here we see there is the proportionate short stature, childlike facial appearance with underdeveloped nasal breeze, making the eyes look prominent, and hypoglycemia is common in both of them, but here could be severe because the growth hormone is completely reduced in this condition. And delayed puberty as well as delayed sexual maturation due to defect in the uh, like FSH, LH producing cells of the pituitary gland. And other deficiencies can be seen like the lack of the TSS causes hypothyroidism, which is presented as fatigue, cold intolerance, and various other could be like adrenal insufficiency due to reduced ACTH secretion, and that could manifested as low energy, low blood pressure, inability to handle stress, and also the serum growth hormone will be low in the case of the pituitary dwarfism, which is elevated in the Laron dwarfism. But the serum insulin like growth factor will be reduced in both of the cases. And the treatment of the dwarfism could be, what type of the dwarfism is it. For example, like the Laron dwarfism, where there is a growth hormone receptor uh, defect or dysfunction, then the administration of growth hormone in those patients could be ineffective. So in those patients, the direct recombinant IGF therapy can be given so that the mutated growth hormone receptor can be bypassed, and growth can be directly stimulated. And next, the pituitary dwarfism could be corrected by involving the replacement of all the deficient hormones like the recombinant growth hormone for the growth, and levothyroxine for the thyroid hormone, and hydrocortisone for the cortisol, and sex hormone estrogen, testosterone, and the appropriate age for puberty. This much for today. Thank